Yeah, I asked you guys to send questions that you had, especially in regard to patients that weren't getting better. I always try to teach and in the office note whether or not somebody has joint instability. So when somebody isn't getting better, the first thing I do is try to figure out at the site where there's pain, do they or do they not have joint instability? So this case was sent to me by you guys. It was a 40-year-old who the doctor has done a lot of things and the patient still complains of pain here. But you'll notice there's no assessment of whether or not the person had joint instability or they have it now. And then if the person had joint instability in the elbow, what is the stability or instability in the shoulder and the wrist? For instance, how long did the person have pain? Let's just say this person had this complaint for 5 years. Well, if they have the complaint for 5 years, most likely it isn't just the medial condyle causing the pain. It's probably that they have instability of the elbow. So again, just doing a valgus stress on the elbow, is there joint play? And under ultrasound, does it open up? Then obviously if somebody has distal radial ulnar instability and this joint is loose, the radial ulnar joint is loose. So in the wrist, right here, if you just did a shearing force, is there clicking, popping, grinding here? And if there is instability here and you're just treating here, this thing's never going to get all the way better. They may get partially better. The other thing in regard to this case is, what are the forces on the elbow that the person does all the time? For instance, is this person playing golf? Is this person playing tennis? What are their activity levels like? Sometimes it's actually the person could just be somebody who uses the computer a lot, but they're always resting the medial part of their elbow on a hard surface. So you just shouldn't do that because, again, just pressure all the time, right? It'd be better to be like this instead of resting your elbow on the surface. So is there instability here? And if there's instability in the wrist, the patient has to get that treated. Do you have to do a neoprene sleeve or something after a treatment so the person doesn't have excessive forces on the elbow? That would be another recommendation. How's the shoulder? The medial antebrachial nerve, the medial antebrachial cutaneous nerve, innervates this part of the elbow. That is a branch of the lower trunk of the brachial plexus, which we all know when you have thoracic outlet syndrome or something like that, or you have shoulder instability, that can affect the ulnar nerve, the lower trunk of the brachial plexus. And of course, that could affect the medial antebrachial nerve. So again, I would ask, do they need prolotherapy of the shoulder? So in summary of this case, obviously something has to change. Either the forces have to change. So I talked about those. Do a neoprene sleeve, or maybe you have to limit golf or tennis. And then if they're using the computer a lot, are they putting a lot of force on the medial side? How's their elbow? How's their wrist? How's their shoulder? If those are unstable, then of course you have to treat those. The other thing is, how frequently is the person being seen? Because if the person's being seen too infrequently and they're getting unstable in between the visits, then you may have to see them more frequently. And again, this is a similar case where they had limited effect with common extensor injection, pain provoked when elbow is flexed. So again, I would say that probably the person is not getting the ligaments treated effectively. So in other words, somebody has pain here, they have pain on the common extensor tendon. Well, I would ask the doctor, did you assess them? Do they have joint instability on the radial side here? And it doesn't look like they treated the annular ligament or the radial collateral ligament. So this case is kind of the classic case of a doctor being an injector and not a healer. Like a healer would be, well, why did the common extensor tendon get degenerated or get torn? It's because they have radial side of the elbow instability. So the way to resolve this case is you have to treat the ligaments. I would say, and you guys know this, is that the ligaments being treated is far more important than the extensor tendon. So you have to treat the ligaments. This is somebody who has snapping of the triceps. He was doing strength training, snapping. The doctor tried a ulnar nerve hydrodissection, which didn't work. Well, again, I would say the problem is elbow instability. This person has elbow instability until proven otherwise. So unless they did some awful weightlifting thing where they tore the triceps or something, and you have to do PRP in there, this doesn't sound like it. Any sort of snapping hip, snapping shoulder, snapping scapula, snapping elbow, it's almost always because of joint instability. When the joint is moving excessively, the triceps can start snapping along the ulnar or along the humerus bone. So snapping often is that there's a rubbing of the tendon along a bone. So why is the bone, snapping along the tendon, or why is the bone rubbing on the tendon? It has to be, there's excessive bone motion. So modern medicine emphasizes, the tendon. They don't emphasize, no, it's the joint moving too much. So you have to treat the ligaments. So I would do a comprehensive treatment all along the various joints, the humeral radial joint, the humeral ulnar joint. And if you do that and you stabilize the joint, my belief is then the snapping triceps is going to go away.